Oh, yes. Good evening, all. I'm Rohit Kotaude. I'm working as a product executive at Derma. I'm welcome you all for DADI Dermapath Academy and Diagnostic India Private Limited presented analyze real world dermatopathology cases and histopathology with educational support by Glorama. Before starting the presentation, I would like to thank you to Sasi sir, Nandakumar sir, and Manoj sir to giving an opportunity to present and organize this webinar. So I would like to introduce about the Glorama. So Glorama have a core value that is the elevating life, and the core purpose is elevating life, and core value is to meaningful innovation, unwavering commitment to the quality and safety, continuous improvement and result through teamwork. We have an aspiration core value that is customer success above all else. Glorama have a first company who is launching 7+ products and 400+ enterprising Gloramians. Glorama have a 130+ ranked pharma company in country, and Glorama have a 700+ distribution channels. Along with that, 9,000+ associated dermatologists. Glorama have a skilled R&D team and develop innovative formulation. So we have a product mix like a antifungal, moisturizer, acne care, and hair care. Along with that, we have a psoriasis care, topical steroid, vitiligo care, and nutraceutical. So Glorama is India's first company to make all products paraben-free, sulfate-free, and detergent-free. So Glorama always the patient safety is of a paramount concern. Now I would like to introduce about our flagship brand that is Moist, the most advanced moisturizer and cleanser. Now Moist is a clinically tested and proven. So in Moist, we have a Moist LMA 48, which is a long moisturizing formula. Along with that, we have a Moist Excel. Also, we have a cleansing range that is a cleansing lotion and Syndet bar. Also, we have a Moist cream and Moist MM. Also, we have an advanced formula of Kion, which containing ketoconazole. The advantage of solubilized ketoconazole in lipid phase. In Kion, we have a stay on lotion, Kion soap, Kion zip, Kion tablet, and Kion cream. Also, Glorama has introducing the MinoBoost range, which containing minoxidil in the management of early stage androgenic alopecia and advanced hair loss. So in MinoBoost, we have MinoBoost 5, MinoBoost F5, MinoBoost F10, and MinoBoost Pro Gain. Along with that, we have a oral minoxidil, which is MinoBoost 2.5 mg scored tablet. Also, all pack containing QR code, which is supported to the patient educational information and application video. Glorama is India's first company who is launching novel non-fluorinated topical quinoline, which is Ozdex, ozenoxacin cream and lotion. Ozdex, move on the Zen next. Glorama have a tie-up with the Sanosun baby care range, which is made in German brand. So Glorama tie-up with the Man & Shoulder, the Bring world-class derma tested certified with a natural and safe baby skincare products to Indian mothers. So Sanosun baby German's premium baby skincare, one global, one formulation with 14+ years of expertise in baby skincare and presence in 70+ countries. So Sanosun baby till now gained the trust and confidence of 250,000+ Indian mothers. So Sanosun baby more than 90% natural ingredients. Sanosun baby is made with the SLS and SLS paraben free formula, and Sanosun baby is clinically tested hypoallergic. Sanosun baby with a milk protein and organic olive oil. So that's all about Glorama. Thank you so much. Now I would like to hold the lecture to Dr. Sasi Singh.
Thank you very much, Rohit, for all your support, and thank you entire Glorama technical support team. So we're going to start this 7th CPC session here. I see we've got 3 participants here, Dr. Vishwambari, Dr. Priyanka Kove, and Dr. Sharmina. Dr. Sharmina, I believe you've got to leave early, but that's fine. Before we start, can I get all the fellow panelists to introduce themselves? Obviously, everybody knows Dr. Nandakumar sir, and we are missing Dr. Manoj Singh sir, and maybe he'll be joining in a second. So myself and Dr. Nandakumar sir will be moderating the session, and we'll be guiding you, Dr. Vishwambari, Dr. Priyanka, and Dr. Sharmina as we go through the cases. And I hope all three of you have seen the cases today. So maybe you can start by introducing yourselves. Probably just switch on the camera for the audience and just quickly introduce yourselves before we go ahead. Starting with maybe Dr. Dr. Vishwambari.
Good evening, sir. Good evening, everyone. I'm Dr. Vishwambari. I'm from Nellore.
Go ahead, ma'am. Do you have any experience in Dermpath, or are you just here to learn? What is your...
I'm just here to learn, sir. I'm interested in dermatopathology. So I started learning.
Are you a pathologist or dermatologist?
Sir, I'm dermatologist. I'm working as assistant professor in government medical college.
Okay. Hello.
Yes, sir.
Welcome, ma'am. So, Dr. Vishwambari was very anxious about joining the panel because she said that she did not have any experience, but I've assured her that we are going to be it's just a teaching session and she doesn't need to worry. So, hopefully you'll have a good experience out of this. So, nothing to worry. We'll guide you through the session now.
Okay.
So, Dr. Priyanka, you've switched on the camera, so maybe you can introduce yourself. Dr. Priyanka, yeah, go ahead.
Good evening, sir. I'm Dr. Priyanka Kovid. I'm working as assistant professor at AIIMS Nagpur in the Department of Dermatology.
Nice. And what is your Dermpath experience so far, ma'am?
Sir, I have not taken any specific fellowship or any observership in Dermpath, but I do have an interest as I see a lot of clinical cases, and I have been to institute after my PG. So.
Okay, excellent. Dr. Sharmina?
Yes. Good evening. I'm Dr. Sharmina. I'm a pathologist by training. I'm currently working in Dubai. I trained in Kerala. I'm from Kerala. I've attended Dr. Nandakumar's sessions many times for the IAPM. I'm not currently doing much dermatopathology, but I've always had an interest to learn what you call the algorithmic approach, how to approach skin biopsy. So that's why I'm here.
You took your MD from which college?
From Calicut, sir. I was Dr. Aravindan's student.
Good. Okay. Nice meeting you.
Yes, thank you, sir.
Excellent. So, since Dr. Sharmina, you said you have to leave, how long are you going to be here for? Maybe you can then start the first case with you.
Yeah, I don't think, sir. Actually, I joined out of interest. I don't think I'll be able to contribute much today.
Okay. Do you want to go through the first case for the next 5-10 minutes, and then you can maybe, if you leave, if you want to?
No, I don't think so, sir. I'm not actually 100% free. I joined out of interest because I had approached you.
Okay. No problem. Okay. We'll go ahead with Dr. Vishwambari and Dr. Priyanka over then. Dr. Priyanka, maybe do you want to start off with the first case? You've seen all the cases, Dr. Priyanka?
Yes, sir. I have seen the cases, sir.
Okay. Then let's just go through the cases. It's a very informal teaching session, so don't worry about making mistakes or anything. I just want you to describe as you see. So this is the first case. Let me go back. Sorry. Just a second.
History.
Now. So this is case one is a 59-year-old male with severe itching and multiple vesicles and bullae on the upper limbs. Erythematous dermatitic rash observed on the trunk, neck, and thighs. So this is the clinical picture. You see a lot of bullae and a few vesicles, armpits, also upper limbs. You see a lot of bullae as well here. Bit of erythematous dermatitic background here. Similar rash on the legs, on the hands and the other areas. So these are the clinical pictures. You would have had I didn't give you any clinical differentials here on purpose because I didn't want to divert you. Often it's good to see pathology images without any bias. In fact, even the clinical is a bias actually. So in fact, seeing the histology on its own is actually a good idea because that will avoid you becoming biased. Okay. So, Dr. Priyanka, then what is the impression looking at the lower part of this histology section?
Sir, on low power, I can make out that the pathology is in the dermis and the epidermis is unremarkable and predominantly the pathology is in the upper part of the dermis.
So if you went through any of the basic Dermpath lectures anywhere, you would know that we divide inflammatory. So it is an inflammatory skin disease, right? Not a neoplastic disease, right? It's
Yes,
pretty
sir.
obvious. So
Yes,
inflammatory disease are normally divided into spongiotic, psoriasiform, lichenoid, vasculitic, immunobullous, Okay,
Yes.
so which and paniclitis, etc. Which do you think this falls under?
So this is looking like a vesiculobullous type of
Yes, so this is a vesiculobullous. So how do you classify vesiculobullous?
So it is suprabasal,
Okay.
and then subcorneal, then intraepidermal pattern, and then
Yes.
in sub. Yes, sir.
Go ahead, go ahead.
Then in subepidermal, we have, sir, inflammatory, infiltrate rich and infiltrate poor,
Right.
cell
So,
poor.
yes, so the basic classification is we start with above subcorneal, intraepidermal or intraepidermal itself. Suprabasal comes under intraepidermal. And then you have the subepidermal blister. And then within that, you can have cell poor, cell rich, different cells and different types. Based on that, you classify. Now, given the appearance here on low power itself, can you classify this in any particular way? Which of what we've discussed, major four patterns,
Yes, sir.
subcorneal, intraepidermal or suprabasal, subepidermal, which does it fall under?
Sir, it falls under a subepidermal pattern.
Subepidermal, and it is pretty clear, right? Sometimes it is not obvious until we go higher part, but here you can see that here clear split at
Yes.
just below the epidermis. You can see the nice epidermis here. All these are epidermal keratinocytes. And if I go higher part, you can clearly make out that the split is subepidermal. You're seeing the basal layer here. And how do you know this is the basal layer, Dr. Priyanka?
Sir, if I see the normal part of the epidermis, I can make out the part from where the split is starting. That edge is showing the melanocytes are seen in the upper part.
Absolutely.
And I can see the capillaries and small vessels in the lower part.
Yes, so absolutely. So you're seeing the basal cells, the basal layer, and you're seeing the pigmented basal layer here. And basal layer usually has slightly more columnar cells rather than the cuboidal cells that we see in the higher epidermis, right?
Yes.
So that's how, and if the roof of the blister is formed by these the basal layer cells, which are especially pigmented, as in this case, which often happens with the basal epidermis, then we know that it's a subepidermal blister. But sometimes it can be confusing. Sometimes you see an old blister where or re-epithelializing blister, where some of the part of the blister appears intraepidermal, but it isn't. So here it is clear-cut subepidermal blister, right? You're
Yes.
happy with that. Okay. So now you want to, so when we classify blisters, we look at the site, as you said, the location of blister. Second, you said about the type of cells, right?
Yes,
So
sir.
that is what we're looking at. What are the type of cells here? What do you think these are?
Sir, I can see mostly are neutrophilic, and some are eosinophils. So neutrophils are more than the eosinophils, I feel, sir.
Absolutely, you're quite right. So how do you differentiate neutrophils from eosinophils?
So eosinophils are the very clear-cut pink cytoplasm or the eosinophilic cytoplasm with a bilobe nucleus.
Yes, so
Whereas,
for example, here, this is a bilobe nucleus with eosinophilic cytoplasm, right? What I'm pointing at.
yes, sir.
So that's eosinophil, and then neutrophils are polymorphs,
Yes,
which are
sir.
multiple nuclei, and they're pretty obvious. And you
Correct.
contrast them with lymphocytes, which are mononuclear cells like this. These are much larger nucleus. So this is so predominantly subepidermal blister with a lot of neutrophils with some eosinophils, right?
Yes, sir.
So when you're thinking about a subepidermal blister, leave alone the clinical. If you're
Yes.
thinking of a subepidermal blister with neutrophils, what are your differentials normally? Ignore this case.
Right,
I'm talking
sir.
about in general. If you're teaching theory to a student, what would you think of?
Sir, I would think of some drug reaction like bullous drug reaction or yes, sir. Erythema multiforme.
Okay.
Yes, sir.
Anything else?
Some
Subepidermal blister with neutrophils.
then dermatitis herpetiformis will come.
Okay. Yes. Yes. Anything else?
Then I can have that inflammatory reach porphyria cutaneous tarda rarely.
Inflammatory porphyria cutaneous tarda. Usually, it's not neutrophil rich. It usually presents with a PCT is one of the examples of a cell poor blister usually. So usually don't have cells in it. It's usually non-inflammatory.
Okay.
Okay. Anything else that you can think
And
of?
so
Maybe
epidermolysis bullosa acquisita, the inflammatory variant.
yes, EBA inflammatory variant also is a good example. So Dr. Vishwambari, can you think of any other differentials that come to your mind for a subepidermal blister with neutrophils?
I first thought of epidermolysis bullosa acquisita.
Right.
Um,
The inflammatory variant.
yes,
Usually
sir.
it's
Inflammatory.
non-inflammatory, right? Anything else that you can think of that has neutrophils?
Late stage of bullous pemphigoid. Not really
I
late.
wouldn't say necessarily late stage. There is a neutrophil rich variant of bullous pemphigoid that can present with neutrophils and some eosinophils. So yes, neutrophil rich variant of bullous pemphigoid. So generally, bullous pemphigoid, what are the type of inflammatory cells that we usually see?
Eosinophil rich.
Eosinophil rich. So you are seeing some eosinophils. Sometimes you can see neutrophils. That necessary. I'm not sure it necessarily depends on stage. Sometimes bullous pemphigoid is neutrophil rich. I'm not sure it necessarily depends on the stage of the disease. Anything else? Any other differentials you can think of?
We can think of dermatitis herpetiformis.
DH has already been mentioned. Inflammatory EBA has been mentioned.
Mm.
So the other common subepidermal neutrophilic disorders we think of, when you think of DH, immediately you have to think of linear IgA disease. Okay, because both are related in the sense. So, so if you have, subepidermal neutrophils, linear IgA, bullous pemphigoid, sorry, DH. Then the other common diseases are, apart from inflammatory EBA, SLE is the bullous SLE is the other differential. Okay, so bullous SLE. Inflammatory EBA, BH, then linear IgA disease, and what we discussed now is bullous pemphigoid, the neutrophil-rich variant, are the common differentials we think about when we're seeing a subepidermal neutrophil-rich blister. So then, are there any other clues that may help us narrow these down? Any ideas? Don't worry if you don't know. We are just discussing here. Don't worry. Both of you can comment.
Sir, like if we are thinking of any drug-related pathology, then we would also see apoptotic keratinocytes, some changes in the epidermal necrosis or epidermal damage because it's acute condition.
Absolutely, you're quite right. So in drug-related blistering disorders, you normally see a mixture of patterns. So you can see a lichenoid, spongiotic, and associated with that inflammatory with a blistering pattern. So here, do you think there are any apoptotic keratinocytes or anything else? Is there any other feature? Is there any other epidermal change here that you're seeing?
No, sir. Epidermis
Is this normal epidermis? Otherwise, is the roof normal?
yes, sir. But I can just make out the effacement of the ridges are quite flattened here. That's
Yeah, any blistering disease will efface the retty ridges because once the retty ridges are really only seen because the collagen is pulling some areas down. Once the blister becomes free, once there is a blister, the epidermis actually looks flat. Okay, normally you see the festooning of the dermal papillae at the base of the blister, which you can see here. But actually, you don't see the corresponding. Once the blister forms, you don't see the corresponding retty ridges on top usually of the epidermis.
okay.
The epidermis itself is generally flat, and once it becomes detached, you don't see the retty ridges as such. Some places you see, but this is. Do you know what this is? Is this a retty ridge? Any idea what this may be? This elongated structure here.
Yes, sir. Cut part.
This may be a retty ridge, but I think this is more likely to be an acrosyringium and eccrine gland going through. I may be wrong, but generally, if you're seeing that pattern, this usually may be a eccrine gland, this thing going up. But you're not seeing the lumen here, I have to say. Okay, so going back to the patterns, any other clues for SLE?
Yes, sir. In case of if we are thinking of bullous lupus erythematosus, then we can see basal layer vacuolization and basement membrane thickening, along with the yes.
Go ahead.
Along with sir subepidermal split.
Yes, subepidermal split is anyway there. So basal cell vacuolation is a good clue to bullous SLE. If it's there, that's a good clue. but may not be there in the bullous variant. Sometimes it may be difficult to discern, especially when the the blister is the roof is completely detached. It may not be that visible. The other clue is you may see a superficial and deep perivascular lymphocytic infiltrate, which is much more denser than this. This is a mild infiltrate which you expect with any inflammatory condition. So that is one more clue. The basement membrane thickening is only seen in DLE, in the chronic variant. In acute LE, especially in the blistering variant, there's not enough time for the basement membrane to thicken, right? And especially when the epidermis is detached, there is no chance of the basement membrane being thickened anyway. So basement membrane thickening is not seen in SLE, it's seen in DLE, right? That's a feature of DLE, usually a chronic LE. It's not a feature of acute LE. Okay, so that's that. What about DH? Are there any clues to DH here, or what are the clues to DH usually?
Sir, in dermatitis herpetiformis, the infiltrate will be typically located at the tips of the dermal papillae. Here,
absolutely. So normally you don't see such a big confluent bulla. You see small papillary dermal microabscesses in DH. And it's also the same case with linear IgA. You may see more papillary dermal microabscess rather than full-blown blistering, but linear IgA can also show full-blown blistering like this sometimes. So DH, however, you see papillary dermal microabscesses. So given these, Dr. Nandakumar sir, do you have anything to add on the histology? Any other teaching points we have to add before we go to the differentials?
No, I would just like to ask Dr. Priyanka, I mean, how do you, what are the precautions that you will take while doing a biopsy in a case of vesiculobullous lesion? Because we are talking about infiltrate, we are talking about multi-loculated blistering, we are talking about the different types of infiltrate and all. What are the precautions that you will take while doing a biopsy of a vesiculobullous lesion?
So the lesion to be biopsied should be the fresh blister, and it should be taken from the edge of the blister, so that 1/3 of the normal part, normal skin, that will help in finding out the exact site of blister. So 2/3, yes sir, 2/3 of the blister cavity and 1/3 of the normal skin. And it should be a fresh blister.
That's very crucial, isn't it? Especially when our diagnosis to a certain extent depend on the type of infiltrate that we are seeing. Otherwise, there will not be any sanctity for the nature of the infiltrate if it is from a very late lesion. And what are the points in this slide against it being dermatitis herpetiformis?
Yes, sir. As Sasi sir explained, that here the infiltrate is confluent from one end to the other end and not restricted to the tip of the dermal papillae.
Again, the papillary tip microabscesses and multiloculated blister in dermatitis herpetiformis is seen when the biopsy is taken from an early lesion. If it is a late lesion, such a picture may be seen. The multiloculated blister will join together to form a large subepidermal blister. So the timing of the biopsy is very important. Just that point I wish to highlight.
Yes, sir.
Thank you, sir. I think one more differential probably can be discussed is bullous vasculitis can sometimes cause subepidermal blister with neutrophils, but here there's no vasculitis as such. Though there are some neutrophils within the vessel wall, there's some pigment incontinence here. Can you appreciate? Hopefully, this brown is pigment incontinence. That's just because of the split here. There is no true vasculitis to call it a vasculitic blister. Okay, so let's go to the clinical now and the history. Given the findings, then Dr. Vishwambari, maybe you can now contribute as a clinician. Given the findings and the differentials, now given your clinical picture, what would be your final diagnosis, or what would you narrow it down to the differentials and the diagnosis? We've already discussed why it may not be some histological, why the histological features do not favor DH, for example. We've discussed other differentials. So, Dr. Vishwambari?
So it can be most probable diagnosis is bullous pemphigoids.
bullous pemphigoid as your diagnosis because of the age of the patient.
And
Any other,
in the
what
tense
features,
bulle.
what tense bulle, anything else? What are the features against linear IgA? So clinically, you normally see the string of pearls pattern, usually more in younger kids, though elder people can also get it. But usually you don't get these tense large bullae, right?
Yes, sir.
That's against linear IgA. And EBA inflammatory, again, EBA is usually on pressure sites. This is not the typical clinical pattern of EBA, right? And also, if you're thinking about DH, you see normally small vesicles and those pruritus is a common feature. You don't see these large tense bullae. So I think you're right. I agree with you that this is likely to be bullous pemphigoid, but Dr. Nandakumar sir, have you got any other things, or maybe Dr. Priyanka can?
Did the patient have lesions on the palms or soles?
Trunk, neck, and thighs predominantly, not palms and soles.
Right. I mean, clinically, first possibility for me also would be bullous pemphigoid.
Yes, yes. Dr. Priyanka, what about you?
Yes, sir. Bullous pemphigoid with neutrophil rich. That type was there. The diagnosis was there in that.
What was the diagnosis was written somewhere?
So when I was typing, sir, bullous pemphigoid.
Okay. Your diagnosis was there in the list, you're saying. Okay,
in
fine.
the list.
Yeah, when you type it, the diagnosis will come up anyway. Okay. So yes, this is indeed my final diagnosis was neutrophil-rich bullous pemphigoid, and that's what patient was diagnosed as. Nandakumar sir, so what is the value of immunofluorescence in this case, sir? As a clinician, as a dermatopathologist, would you recommend immunofluorescence to confirm the diagnosis in these cases, or are you happy to sign it out as consistent with bullous pemphigoid and you can treat the patient as this?
No, I would ask for immunofluorescence.
You would ask for immunofluorescence, right? Okay. Because this is interesting because I was recently talking at the SIG Dermatopathology in Dermacon, and we had a debate, immunofluorescence in bullous diseases for and against, and I was speaking against this thing. In fact, I actually believe in it, and it's a personal opinion, of course. But I think in most of these cases, especially a case like this, where it is largely typical and the clinician thinks it's bullous pemphigoid, and the histology is consistent with bullous pemphigoid, I'm not sure that immunofluorescence may help you confirm the diagnosis, but we've already discussed based on this that the diagnosis is fairly certain it's bullous pemphigoid. So it won't change the management, in my opinion. And therefore, I don't normally recommend immunofluorescence in all cases of bullous diseases as a routine, unless I have a diagnostic doubt clinically and the CPC does not match. So that is my practice. But it's interesting that you would recommend immunofluorescence.
I agree with what you're saying, but my general view is that in subepidermal blistering diseases, we will be helped by the immunofluorescence pattern also. I don't ask for immunofluorescence in all cases of intraepidermal blistering diseases, but in subepidermal blistering disease, I'd be happy to have immunofluorescence correlation also.
So if there is no immunofluorescence in this case, sir, what would you sign it out as? Would you just give a
I would still call it as bullous pemphigoid, neutrophil rich. I agree. And if the patient cannot afford to do the DIF also, we will have to sign it off as bullous pemphigoid.
Yes. You would have no medical legal worries about calling it bullous pemphigoid, despite the lack of.
Yes. No. Because I can substantiate my diagnosis by the findings.
Absolutely. That's what I was getting at. Yes. Okay. So let's see what everybody has called it. I think there were 35 participants. 20 of them have called it bullous pemphigoid neutrophil rich, which is excellent. So I think we'll give them 1 mark. I'm not sure that linear IgA, should be given marks, but it is a subepidermal neutrophilic blistering disorder. For them identifying it, if you want to give marks, 0.25 is a reasonable one. Dr. Nandakumar sir, what do you think?
0.25 because 0.25. Because the CPC doesn't match.
Yes.
For some credit for identifying it as a subepidermal blister.
Yes. I think bullous pemphigoid, again, whether it's neutrophil rich or not, I think full marks for that, again, I think would be reasonable.
Yes.
But if we want to differentiate them because neutrophil rich is also in the differential, They have not put that. So if we want to penalize them for not specifying it, 0.75 is
Well,
reasonable.
I think we are in the final diagnosis as per histopathology is neutrophil rich BP. So for plain BP, we will give 0.75.
0.75 I think is reasonable, yes. DH again, if you are giving this one linear IgA, then DH also 0.25 is not unreasonable.
Yes.
But then subepidermal bullous disease is a very non-specific. I'm not sure. You have to be very generous to give that one.
No, because we are only giving 0.25 for dermatitis herpetiformis, no?
Yeah. And again, bullous pemphigoid cell poor is not the answer. Though
No,
they've specified bullous pemphigoid, I don't think
Again-
any of these should be given anything. Bullous SLE again. I don't know. Bullous SLE can be given 0.25 for again them. Again, these two, if you are sticking to that, 0.25 and 0.25 can be given, I guess, for these two.
Yes. We can.
But calling it cell poor is a wrong diagnosis. So we can't give that.
We cannot give. We cannot.
Shall we submit this as it is? Happy with the final.
The rest will get only 0.
Yes. Okay. So next, going to case 2, we've had a big discussion for the first case. So we'll have to hurry up for the remaining ones. So case number 2, Dr. Nandakumar sir, you can maybe take this forward. I didn't give any clinical here, pictures here. 40-year-old male with itchy, hyperpigmented scaly lesions all over the body since 10 years. Diagnosed with mycosis fungoides and treated with phototherapy. For the past 3 months, patients reports new itchy scaly lesions all over the body with enlarged non-tender left cervical and inguinal lymph nodes. Non-tender lymph nodes. They didn't give the size or anything else. No organomegaly is noted. And this is the histology. Okay. Dr. Nandakumar sir, on this.
Dr. Vishwambari, would you start describing the findings? The scanner view? Please go ahead.
Yeah.
Don't worry, ma'am. Don't.
Absolutely. This is just a friendly discussion. We are learning from each other. Please go ahead.
Reaction pattern is predominantly in upper dermis.
Yeah. We
and
heard the
involving
history.
epidermis.
We heard the history, isn't it? We heard the history.
Yes, sir.
I think we can go to the next. Can you just zoom in a bit? Right. Yes, good.
So, Dr. Vishwambari, you have to learn to ignore the artifact. So, this is a cutting artifact. The epidermis is missing here. So, this is I deliberately putting these cases because this is routine, reporting, and we often see these artifacts, and we have to learn to ignore them. This is not an ulcer. This is not a blister. This is just a cutting artifact where some of the epidermis is missed. Similarly, this is not a blister. This is a cutting artifact, and we make it out because there's no sebum within that, and this is actually in the dermis. It is under the dermis, under the epidermis, under the papillary dermis. So this is again a cutting artifact. So just want to highlight that these things have to be ignored. So don't be confused by these spaces here, okay? And this again is a dust particle in the scanner slide. You may see that in the normal slide also. So again, ignore these things. And I'm explaining these because it's important, because as a beginner, you may not know. Please go ahead.
I think this is a good area of the section to describe the findings. Start from the stratum corneum. What are you seeing in the stratum corneum? Just go in an orderly manner.
I'll zoom in for better understanding.
What do you see in the epidermis? Don't worry about the diagnosis. Just tell me what are the findings that you see in the epidermis.
Compact orthokeratosis with little basket wave pattern.
No, we are seeing some parakeratosis also. Right?
Yes, sir. Parakeratosis is there.
Essentially, the epidermis looks a bit atrophic, isn't it?
Yes, sir.
Flattening of rete ridges are seen. So, a hyperkeratotic, focally parakeratotic, atrophic epidermis. What do we see in the basal cell layer?
No, sir. There is a degeneration, vacuolar degeneration.
Vacuolar degeneration. Okay, I think that summarizes the histological findings with regards to the epidermis. Coming to the papillary dermis, what do you find?
Uh,
In other words,
lymphocytic infiltrate.
we have a history that the patient is a diagnostic mycosis fungoides. I mean, do you think there are atypical cells among the infiltrate? Obviously, there is no appreciable epidermal tropism, isn't it?
Yes, sir.
We are not seeing any epidermal tropism per se. The slight exocytosis of few cells into the basal cellular, I agree. Yeah, please go ahead. We'll just discuss. We are seeing some dilated capillaries are there. Pigment incontinence is seen.
There are multiple dilated capillaries.
Pigment incontinence is seen.
Yes, sir. Pigment incontinence is there.
Yeah, what is the nature of the infiltrate?
Lymphocyte predominant, sir.
Lymphocyte predominant. And the lymphocytes looks quite mature and benign, isn't it?
Yes.
Yeah, there is no cellular atypia. So the history, once again, the patient recently developed scaly lesions, isn't it, Dr. Sasi?
So lichenoid lesions, which are slightly itchy lichenoid lesions since 3 months, known patient of mycosis fungoides since 10 years with hypo and hyperpigmented patches all over the body. And he had phototherapy also previously. Now, since 3 months, lichenoid itchy lesions all over the body. And the clinician wondered if it's MF transformation or something else.
So can you answer the question? Is it MF or something else? What is the type of tissue reaction here? I mean reaction pattern here.
Interface dermatitis.
Interface. Yes.
With vacuolar degeneration is predominant.
Yeah, good, very good. Now we have to, with CPC, we have to arrive at a clinical pathological diagnosis, isn't it?
Yes.
Doesn't help the clinician much just to call it as an interface dermatitis. What could be the patient be having now?
Post-radiation dermatitis.
No, they didn't have radiation. They only had phototherapy. Okay. Didn't have radiation actually.
It shows like lichenoid interface dermatitis. Yes, Dr. Sasi, you were saying something?
Yeah, I just want to point out these cells here and see if Dr. Vishwambari or Dr. Priyanka would want to comment on these. What do you want to call these cells, Dr. Vishwambari? Do you have any clue? There is some pinkish thing here, and then these cells here, this cell here. Any particular term or name you want to give them? And this cell here, for example, this cell here, for example.
Those are all extravasated RBCs.
You see the red, isn't it? These are extravasated RBCs here. RBCs don't go into the epidermis usually. This is one extravasated RBC. That's because of the blood spilling onto the tissue from top. In the epidermis itself, it's unlikely to see extravasated RBCs unless you're seeing a cross-cut papilla. Here, the nucleus is quite big, isn't it? It's a big nucleus with a perinuclear vacuolation. Right? And here, if you look at it in another place, here the nucleus has become a bit more pycnotic. It's become slightly more hyperchromatic and pycnotic. Here also. These are basically degenerate keratinocytes, right?
Sir?
Yeah, go ahead, Dr. Priyanka.
Sir, can you just, we are not able to see the pointer, sir.
Oh, you're not able to see the pointer? Okay.
Yeah, I'm also not seeing the pointer.
Oh, okay. I have to see how to get the pointer then because I'm pointing. Okay. Maybe right in the middle of the screen, I'll put them so that it's easier. So yeah, you can see this.
Yes.
You'll be able to go out better. Okay.
Yeah.
Yes.
For some reason, the pointer on my screen is not going there. Okay, fine. We'll have to fix that next time. Okay. So right in the middle of the screen, you can see these cells, right? And again, if you look at here, This is also a degenerate, right in the middle of screen. If I zoom back again, you can see that here. This is what I'm moving is a degenerate keratinocytes. All these are apoptotic keratinocytes. All the big cells with vacuolation around. Yeah. Can you make that out? Dr. Vishwambhai, can you make that out? Is
Yes,
that
sir.
clear enough for you?
Yes,
And here also, if you see right in the middle of the screen, you're seeing these big cells with vacuoles around. These are degenerate keratinocytes. And this is just vacuolar interface change. So you're bound to see degenerate keratinocytes, right?
okay, sir.
Okay. So Nandakumar sir, your
Yeah.
diagnosis.
I would call it as, lichenoid interface dermatitis, possibly resulting from chemotherapy.
Patient didn't have chemotherapy, sir. Only had phototherapy.
Phototherapy, right.
So that was also a long time ago. That's nothing recent. The patient, these lesions have occurred on their own. No particular trigger. So the clinical differential diagnosis the clinician gave was actually lichen planus. Or lichenoid, drug-induced lichenoid dermatitis, though there were no drugs. So yeah, given that, so the basic thing we need to answer here is it MF or not? And is it MF transforming? We can be 100% certain given the lack of epidermotropism, lack of lymphocytes, atypical lymphocytes percolating in the epidermis, that this is not MF transformation. So this is more of a lichenoid dermatitis as we've discussed. So the clinician has to correlate, is this lichen planus or a variant of it or a drug-induced lichenoid dermatitis? So anything in this spectrum would get full marks in my opinion.
Yes, I agree.
Yes. Dr. Priyanka and Dr. Vishwambhai, have you got any doubts regarding this case? I don't think there are any other findings that we need to particularly, highlight.
Yes,
Yes,
sir,
there
agree
may
with.
be some thickening of the basement membrane somewhat, but it's again non-specific in this particular circumstance. Lots of pigment incontinence.
I think the main thing is that we should pick up the reaction pattern in this
Yes.
slide. We are seeing an interface dermatitis with plenty of basal cell vacuolation, and as Sasi pointed out, good number of necrotic keratinocytes are seen. Pigment incontinence is very prominent, and we are seeing mature lymphocytes almost confined to the papillary dermis.
Yes.
But it doesn't look like a classical lichen planus to me. That's all.
Yes. Classical lichen planus would have, lichenoid, much more lichenoid rather than vacuolar pattern. And also,
Yes.
you don't see this much atrophy unless it's atrophic lichen planus where you can see this pattern.
Yeah.
Atrophic lichen planus, you can see this pattern, of course. So it's in the lichenoid spectrum, but not.
Yes.
It's not a mycosis fungoides right now. Nobody can diagnose mycosis fungoides on this slide, right? That is the bottom line.
Yes, exactly. We shouldn't get carried away by the history of patient having
Yes,
mycosis
absolutely.
fungoides.
So unfortunately, it looks like the participants have. Somebody has called it plaque stage. 12 of them have called it plaque stage. 8 of them have called it PAT stage. Somebody has called it pseudo-Sézary syndrome. I don't know where that came from. Erythroderma NOS, CD8MF, UV-related phototoxic dermatitis. Nobody has gone into lichenoid for some reason.
Yeah,
So
number 12.
Somebody has called it bullous LP. I guess they were confused by the artifact there.
Artifact, yes.
So bullous LP. Lichenoid dermatitis NOS is the right answer.
Yes.
And I'm going to give that 1 mark. I'm not going to give any marks for anything else, unfortunately. Parapsoriasis is such a dustbin diagnosis. I'm not going to give that any answer here in this particular scenario. I don't know. Dr. Nandakumar said you want to. No. So only one person has got full marks. The rest have not got any marks on this one.
Yeah, I think the learning thing is that we shouldn't be biased by the clinical history given.
Yes.
We should be objective in assessing the histological findings.
Absolutely.
And in this particular case, CPC would be crucial also in the management of the patient.
Yes. So I thought this was a pretty, it's a routine sign out, but I thought it's a very good discussion, right? I mean, it's an interesting thing to discuss, and it's good that a lot of people have got it wrong. So it means that we put the case rightly. It's a good discussion case. So this is the next case. Oh, sorry, let's go to the history. Actually, to be honest, this case is Dr. Manoj Singh sir's case. I don't think he's online. Dr. Manoj Singh sir, are you there? I don't think he's here.
No, he hasn't joined.
So I had to invent the history for it based on the diagnosis given me, but then I'm not sure about the diagnosis either. So it's a good discussion case. So 54-year-old male with erythematous tender plaques on the legs for 6 months is the clinical history, I have slightly cooked up based on the histological findings and the diagnosis given me. So let's go by this, and we'll discuss the histology. So we can be, pretty, it can be just a descriptive diagnosis or discussion here. So Nandakumar sir, you can lead here.
Yeah. Priyanka, you.
Yes. Sir, on scanner view, I can see the pathology is in the dermis, sir, and the epidermis is showing regular psoriasiform hyperplasia with clubbing of the retroridges and regular elongation with psoriasiform hyperplasia. And in the dermis, sir, I can just make out some focal infiltration in the upper dermis on scanner.
We can go closer. Good. This basket weave hyperkeratosis is also there, isn't it?
Yes, sir. And the basal layer, there is also hyperpigmentation of basal layer, or the site is from, sir, it is looking little pigmented.
Right.
Go
till closer. We will go a bit more closer. Yeah. What is the nature of the infiltrate?
So the infiltrate is mostly lymphocytic.
Yeah. I would call it as mononuclear cell infiltrate.
Okay, sir.
That is why that is how I would call them, because they may be mixed with some few plasma cells also. So to be on the safe side, I call them as mononuclear cells. We are seeing mononuclear cells around blood vessels also. We are seeing mononuclear cells.
Yes, sir.
And what else we are seeing in the dermis?
Sir, I can make out again the mononuclear cell and some pigmented cells.
Yeah, so there seems to be some pigment dropping down into the upper dermis.
Yes, sir.
A pigment incontinence is seen. And what else we are seeing? Some dilated capillaries are also seen.
Yes, sir. Dilated capillaries are seen, sir. Yes.
Right. And is there any feature to call it as vasculitis? We are seeing perivascular infiltrate. Is there anything to suggest vasculitis? Here the pigment is very nicely seen.
Yes, sir.
The biopsy is from a lesion on the leg.
Leg, sir. Yes.
Yeah. Do we have the age of the patient?
56.
56. Right. Will you commit on vasculitis with the histology? Is there any fibrinoid necrosis?
Sir, I'm not finding any fibrinoid necrosis.
Don't be apologetic. We are not finding any fibrinoid necrosis. True, correct. So, to summarize the findings at this stage, I agree that it shows somewhat a psoriasiform hyperplasia, but it is not psoriasis. We cannot call it as psoriasis because we are not seeing any parakeratosis. We are not seeing any Monro abscess. And in the upper dermis, there is a moderate to dense mononuclear cell infiltrate located around blood vessels as well as interstitial infiltrate. And towards the mid portion of the dermis, at this point, at this view itself, you can make out the dilated blood vessels with lot of RBCs, isn't it? The extra RBCs are there. And this pigment is so prominent. In light microscopy, we are seeing an intact basal cell layer. So what else could this pigment be? Is it melanin?
No, sir. I just make out few, maybe a spore, brown colored structures I just saw.
You thought about a fungal body.
Yes, sir. So some refractile structures, round and refractile brown colored structures.
Brown colored structures were seen in one place.
Yes, sir.
I'm afraid I don't think so.
So what should be the feature of a fungal infection, ma'am? What should be the reaction pattern in a fungal infection?
Granulomatous.
Granulomatous, or it should be So it should be a granulomatous or at least a neutrophil-rich suppurative granuloma or suppurative abscess formation should be seen. So if you're seeing anything else, it's an artifact actually. I don't
Yeah,
know.
exactly. If the supportive tissue reaction is not seen, and you think that it could be a fungus or something, think about the possibility of it being an artifact, because we are not seeing a supportive tissue reaction. If it is a chromoblastomycosis or pheohyphomycosis, the tissue reaction should be there, isn't it? It is not seen. It is not seen. So it is likely to be an artifact, what we saw as a refractory structure. But what about the pigment? Why there is so much of pigment?
This is what you probably saw.
Yes, sir. Yes, sir. Yes, sir.
Okay, fine. Artifact, not. So the concept of the pigment actually, what is the pigment? Is it what could be the pigment now?
Again, you do the CPC. It is from the leg lesion, isn't it?
Okay. Should be a tattoo. I mean,
There's no history of tattoo. That is not a tattoo. And see, the pigment is extending down to the deep dermis. In fact, going into the almost a subcutaneous. Can you see that?
yes, sir.
So here also there's a bit of pigment here near the fat. In the septum also you're seeing some pigment. This is already going to the fat septa. See, you're seeing pigment here. Can you make out in the right and middle of screen?
Yes, sir. Yes, sir.
You have
This
a
is actually
choice. You have a choice to ask for a histochemical stain, special stain. What special stain you would ask for?
One question, sir. For,
Or what special stain can we do? Are you sure it is melanin? Are you sure it is melanin?
no, sir. It's not melanin.
Then what else it could be?
What is the other brown pigment that you can see in the skin?
With so much of RBC's extravasation and
Hemosiderin.
Okay.
so what special stain you will ask for?
For hemosiderin.
Pearl stain, right? So you would
Pearl
ask for a pearl stain. In fact, the pearl, Nandakumar sir, Manoj Singh sir sent me the pearl stain as well, which I haven't scanned. But
Right.
that's positive for hemosiderin anyway.
Hemosiderin.
So this is hemosiderin, and yeah, this is hemosiderin stain all along. But even without stains, there's no other differential diagnosis. Unless you're thinking of a tattoo, this is hemosiderin, the typical granular, coarse granular nature of this pigment extending in between the collagen bundles. It is hemosiderin unless proven otherwise.
Yes, sir.
Now, what would be the diagnosis?
Sir, pigmented purpuric dermatosis with
It is usually seen as multiple, isn't it?
okay, yes, sir.
So the history again is erythematous tender plaques in the legs for 6 months.
They are tender plaques. I think the one or two points which we have to be clear about this histology is that there is no evident vasculitis.
Yes,
Yes,
absolutely.
sir. Yes, sir.
In spite of the infiltrate being around blood vessels, and we are seeing so many prominent blood vessels and all, no evident vasculitis is seen, and there is plenty of hemosiderin deposit.
Macroangiodermatitis of macro.
So acroangiodermatitis is a good differential because you're thinking about stasis, right?
Yes,
So I
sir.
think Nandakumar sir was also hinting about when he showed you about legs and all that. Stasis-related changes can lead to hemosiderin deposition, but acroangiodermatitis is a specific diagnosis when you're seeing much more, dilated vessels here and neocapillarization. I don't know, Dr. Nandakumar sir, you want to counter that?
Yes, yeah. I wouldn't term it as this particular entity. To me, this is stasis dermatitis with bit of psoriasiform hyperplasia. That is how I will sign off this
Yes,
case.
absolutely. So the tricky part was Dr. Manoj Singh sir sent me this as a vasculitis case, but I'm not sure if that is the right diagnosis because I don't see any vasculitis. There is a perivascular lymphocytic infiltrate, no neutrophils, no definite vasculitis. So unfortunately he's not here to support or refute the diagnosis. But I don't see any vasculitis. Of course, it could be a chronic vasculitis, and we have diagnosed it. We have biopsied a late lesion where you only see hemocytin deposition. There's some collagen thickening which could be site related. So we are not excluding a post-vasculitic phase, but essentially you cannot diagnose vasculitis based on this histology, right, sir?
One learning point is one should know the anatomical, the variations in the histology depending upon the anatomy of the lesion, where the lesion is located. This is located in the lower legs, so that changes would be seen.
Yes.
That is why I asked the age of the patient and all. In a he's only 56. In an elderly patient, lesion occurring on the legs, lot of artifactual changes would be seen due to stasis.
Yes, so stasis-related dermatitis is the probably closest answer. So, Dr. Priyanka, you mentioned psoriasis, psoriasiform dermatitis, and Dr. Nandakumar said this is not psoriasis. I mean, you're quite right in thinking about psoriasiform. Do you think, can you think of any other clues that tell us this is not psoriasis apart from lack of papilledema, microabscess, lack of parakeratosis that Dr. Nandakumar sir mentioned? I mean, as a reporting pathologist, we wouldn't think about psoriasis as the first diagnosis when you think of it. But as a learner, I think psoriasiform hyperplasia is not a bad bad observation. But there are some clues to tell us it's not psoriasis. Do you have any thoughts?
So the granular layer is there, sir.
Very good, very good.
Yes, sir.
Granular layer is there. Anything else?
Yes.
Anything about the pattern of the reticulars that give you an idea?
So the reticulars are quite broad here. They are not thin and elongated. At some
Actually, it's a reverse. In psoriasis, you don't see these thin and elongated. See, they're more thin and elongated here. In psoriasis, you don't see that. This is psoriasis, they're more bulbous. So these sort of bulbous reticulars you see more often in psoriasis. And yes, there is some clubbing here, but clubbing by itself is non-specific. Could be a sectioning artifact as well. When you cut the section tangentially, it may appear clubbed.
Blood vessels.
But here the pattern of the reticulars, they're too pointed for psoriasis. You don't see these pointed pattern of reticulars in psoriasis. That to me is a clue that this is not psoriasis. And also, you can see that there is no suprapapillary plate thinning. That is also another clue. That you can draw a straight line here and it doesn't extend higher up and the epidermis is relatively uniformly thick all throughout.
And in psoriasis, we expect the infiltrate in the dermal papillae, which is completely spared here.
And here the vertical alignment of collagen fibers here to some extent and the hyperplasia suggests that this may be a chronic stasis related thing or chronic pruritic. Maybe the patient has been scratching or rubbing the lesion because of whatever reason. And this suggests that this hyperplasia is secondary rather than a primary pathology.
Yes, even the bit of papillomatosis could be a secondary change.
Absolutely. Okay, so let's go to the answers. Case number 3, pigmented purpuric dermatosis, somebody has called it. Okay. Clinical does not fit in for pigmented purpuric dermatosis.
We usually see a lot of thin-walled capillaries in pigmented purpuric dermatosis in the upper dermis, not like this. I wouldn't call this as pigmented purpuric dermatosis.
Yes, but given that they spotted a perivascular lymphocytic infiltrate and they have seen hemocytin, that's why they're probably calling that.
Yes.
Given that we haven't really given a clinical differential, maybe that is not unreasonable. Giving some points is probably valid, I think.
Yeah, we can give 0.5.
Yeah, 0.5 or 0.25 if you're generous. 0.5, 0.25 also is okay. Up to you, sir. What do you think? 0.5?
0.5.
0.5. Lipodermatosclerosis is very specific.
No.
You have to see some, it is seen in stasis and they're thinking in the right ballpark, but then in the absence of panniculitis, calling it lipodermatosclerosis is a bit tricky.
There is no fibrosis also.
Yes, they've gone by the clinical, I think. And
Yeah.
clinically, if it's an old lesion where the fat is normal, you can actually probably fit into hypodermatosclerosis. I mean, it's not unreasonable given the clinical. I think based on the CPC, they maybe thought this is an old lesion that has been biopsied, right? Because the clinical says erythematous tender plaques on the legs. As an older person with probable stasis.
I don't think we should give credit for
No marks for
lipodermatous.
that. Okay, fine. Happy with that.
And
Septal vasculitis, secondary syphilis.
nobody else get any marks. I just scanned through the diagnosis.
Yeah, so as if from
One
dermatitis.
person has diagnosed lichen aureus.
Stasis dermatitis. There you go, sir. Somebody has got the right answer.
28.
Okay. Yes. Lichen aureus, unfortunately, no, I don't think we can give any marks. Okay. So, right. Okay. So, 4 more cases. We've got half an hour. We'll quickly go through them.
Somebody has made a diagnosis of psoriasis.
Yes, that's
but
we've discussed it. That's good.
Yeah, it's good that we discussed it.
Yes. Okay. So let us go to case number 4. I think this is a relatively easy case. We'll quickly finish this off because we've already been in the spectrum. 64-year-old woman with 2-year history of recurrent tense blisters over the shin and ankle. Individual blisters rupture slowly and heal over weeks, leaving thin scars with occasionally tiny white papules on the edges. Multiple course of topical steroids, poor response. She's otherwise systemically well. I think even without the histology, you can make a diagnosis actually. This is again the clinical picture, which is showing a reasonably tense bulla. And when you're seeing a tense bulla, Dr. Vishwambari, can you what are your clinical differentials based on this?
Clinical differential is bullous pemphigoid, sir, taking the distribution of the lesions and age of the patient.
Dr. Priyanka, what do you agree, or do you have any other differentials?
And
Sir, healing with scarring, and I saw the histopath side. I'm going in favor of epidermolysis bullosa.
acquisite.
Okay, Dr. Vishwambari, what do you think about epidermolysis?
These two are my disease, sir.
Okay, and you favor which one based on the clinical? We have not looked at histology. Based on the clinical, which would you favor?
Epidermolysis bullosa acquisitus.
You favor EBA because of
scarring and milia formation.
Right. Okay, fine. So this is the histology. Dr. Vishwambari, we've already discussed all the features that we should find. Do you want to quickly go through what type of blister is it? Which is the site of blister here?
This is subepidermal blister.
Subepidermal, excellent. And then we're looking at the cells. What type of subepidermal blister is it? Are you seeing a lot of cells?
No, sir. They're very poor, little.
Yes. So it is a cell pore blister, right? So it is a cell pore subepidermal blister. And then therefore your diagnosis? No, so cell pore is usually EBA.
Okay.
EBA is cell pore. It will help if you're seeing milia and a bit of scarring, though you're not seeing milia. So when you're seeing cell pore, the first thing that should come to your mind is EBA. Then the second thing is, what is the other cell pore subepidermal blister that you can see in this setting, which goes with your clinical?
Diabetic.
Diabetic bulle, okay, you can think of that, though. Okay, Dr. Priyanka, what do you think?
Sir, porphyria cutaneous tarda.
Porphyria cutaneous tarda, you can think about. What are the features of PCT while we're here? Anything specific that you should be looking at for PCT?
Sir, the dermal, there will be a festooning of the dermal papilla into the blister cavity.
Excellent. And
it will be a cell pore.
Yes. Any other features around the blood vessels that you may see? So you often see thickened blood vessel walls, which are PAS positive if you do a PAS stain as well. Here, the blood vessel walls appear normal. There's no festooning of dermal papillae. And we didn't think about PCT in the clinical as well. So PCT is unlikely. So the other differential that you have mentioned is initially bullous pemphigoid. Cell pore bullous pemphigoid should also be considered. So bullous pemphigoid does not always need to be cell rich. It can be cell pore. Just as we saw neutrophil-rich bullous pemphigoid, we can have cell-poor bullous pemphigoid. So bullous pemphigoid and EBA are the clinical differentials. Bullous pemphigoid and EBA are the histological differentials. But bullous pemphigoid cell-poor variant is possible. Can we still sign it out as one of the diagnoses based on the CPC? Dr. Nandakumar, sir, you maybe can guide us.
Yeah, this is what I was talking about when we discussed the first case. Here, I think we will have to do immunofluorescence, isn't it?
If you want to be very finicky, okay, sir, the patient cannot afford immunofluorescence.
Okay, then I would sign it off as CBA.
Then you would sign it off as EBA. You're right. If you have immunofluorescence, it would confirm the diagnosis of EBA. But given that the clinical history, poor response to topical steroids, individual blisters heal over weeks, leaving thin scars, tiny white papules which suggest milia, recurrent blisters on the right shin and ankle, which are typical trauma sites, elderly women.
Yeah.
The diagnosis is EBA. If you have immunofluorescence, you can differentiate between cell-poor EBA and cell-poor bullous pemphigoid and EBA. But then, even without it, it's EBA.
It is EBA. It is EBA because the clinical distribution is characteristic of EBA.
Yes, absolutely.
I would sign it off as EBA.
You would sign it off as EBA, and that's what we expect people, contestants to sign it off as. So EBA, cell-poor, majority of them answered, which is excellent. I don't know why they've called it inflammatory. Do we give them any marks? I don't know.
Yeah, we will have to give them some credit for that.
0.5, I think.
0.5.
0.5. I don't know why they called it bullous pemphigoid neutrophil rich. If you call it cell-poor, it's okay. Bullous diabeticorum, some people have called it. Again, we have not even given a history of diabetes. I think that is I don't think that deserves any marks.
No, I don't think so.
Pseudoporphyria, again, I don't think there are any features suggested. Acantholytic bullous disorder, I'm afraid. Bullous pemphigoid cell-poor can be given marks. I think 0.5.
Yes.
Based on the histology alone. Mechanobullous variant of EBA, mechanobullous variant, but that, I don't know. That is same thing as well. So I think we can give it, but not specifically.
The last number 16 has diagnosed it as plain bullous pemphigoid. That should not be given any credit.
Yes.
That is the point. You cannot call it as straightforward bullous pemphigoid based on histology. At least we will have to qualify it as cell-poor, isn't it?
Absolutely. It's not classical bullous pemphigoid.
So we cannot give any.
So
somebody number 12 has diagnosed it as bullous lichen planus.
Yeah, again, no chance of that.
No chance.
Not even lichen. Right. So it's happy with that, sir. Can I submit it as it is?
Yes.
Okay. So 3 more cases in next 20 minutes. Let's quickly go through the cases.
There is lot of, overlaps in the histology of many of these lesions, but we have to be very clear about certain things. Based on histology alone, in this case, you cannot call it as bullous pemphigoid. You cannot sign it off as bullous pemphigoid. At least you will have to mention that the possibility of bullous pemphigoid cell-poor variant may be considered, that a descriptive sentence will have to be added. You cannot straightforward diagnose of bullous pemphigoid. That is wrong. That is a wrong diagnosis. Yes, we'll go to the next case.
So this is case 5, 44-year-old female, dark, raised, itchy lesion on scalp for 4 months. Well-defined, scaly, small plaques scattered on scalp for 4 months. Regions are pruritic in nature, central hyperpigmentation. Query DLE is the differential diagnosis that is given by the clinician. So those are the hyperpigmented plaques that I've seen. So let me slide. Okay. So this is the, okay, that's no part. This is maybe a better slide. Okay, we'll concentrate on this one. Dr. Nandakumar, sir, you can please guide the participants.
Vishwambari, would you like to describe?
I'll go slightly higher part.
Okay. Yeah. It's a relatively simple slide.
So concentrate on the pattern, Dr. Vishwambari. Is it psoriasiform, spongiotic, lichenoid, vasculitic, granulomatous, etc.?
It is having mixed pattern with psoriasiform and spongiotic on low power.
Can we go closer? Yes. Now, let us describe the findings in the epidermis. Quick. We are running out of time. Hyperkeratosis is there?
Yes, sir.
Yeah. This is the, you look at the dermal papillae here. This was what I was talking about.
When the dermal papillae or there is...
See, this was the finding which I was discussing when we discussed that stasis dermatitis. This finding was absent in that particular case. Here, the dermal papillae shows dilated capillaries, and there is good number of lymphocytic infiltrate there, isn't it? The dermal papillae. But just by way of observation. But what about the other changes in the epidermis? Quick. What do you find here on the left hand side? The first dermal papillae, suprapapillary region. What do you find there?
There is degeneration of the basal layer.
I don't think so. There is degeneration. What I wanted to you to appreciate is that the granular cell layer is reduced, isn't it? Number. So this is the focal hypogranulosis. You can see the parakeratosis overlying that area. And
so
we are
this
seeing
is a dermal papilla, ma'am. This is not, so you may be wondering that this is a macular degeneration. This is actually dermal papilla going up. So that is maybe why you're confused. This is the entire dermal papilla going up completely. And this is the suprapapillary plate thinning that Dr. Nandakumar sir was probably wanting you to get at. So you see the suprapapillary plate, there's no plate at all. It's directly in contact with the stratum corneum.
Stratum corneum. So this is the classical hypogranulosis, focal hypogranulosis that we talk about in psoriasis. And we are seeing that almost bulbous regular acanthosis, isn't it?
You see the bulbous thickening and of the base, and then
these are equal.
Well, and they're clubbing together, right?
Did you make out? Did you see any spongiosis?
So any psoriasis can be associated with mild spongiosis because of inflammation, but here it is minimal if at all. So you can't really call this a mixed infiltrate. This is purely psoriatic.
Psoriasis form. It's a quite a straightforward diagnosis. What would you call it? The scalp lesion. We saw the clinical picture also.
Psoriasis.
Psoriasis. Why hesitate? This is classical psoriasis.
That's it. Now, what about the pigment incontinence? Does it suggest a lichenoid infiltrate? Because DLE may be considered, people may think pigment incontinence suggests lichenoid.
Yeah, it was one of the clinical DDs, isn't it? DLE. Is there any lichenoid change here? I don't think so.
No, there isn't. But then we will have to appreciate that pigment incontinence is not specific for interface dermatitis, though it can be seen in all interface dermatitis, most interface dermatitis, but just because you're seeing pigment incontinence does not mean it's an interface dermatitis. Okay, important to remember that. Dr. Priyanka, have you got anything to add?
Sir, just a little, can it be, can lichen simplex chronicus of the scalp be the differential?
I'll let Dr. Nandakumar sir
answer
that.
Yeah. Lichen simplex chronicus, the features that one would see is more of compact hyperkeratosis in the stratum corneum, one. And the acanthosis in lichen simplex chronicus would be more of irregular type. Bulbous nature can be seen, and it will not show any suprapapillary thinning.
Okay.
And one more feature of psoriasis, sometimes you see are these mitotic figures. Can you make this out right in the middle?
Yes, suprabasal mitotic figures. That is a good finding if you can appreciate it.
And these are actually seen only in psoriasis and not seen in other conditions because of the fast rate of multiplication. You often see mitotic figures. I'm trying to pick out ones because I don't have a pointer. It's difficult, but you're seeing lots of few mitotic figures here, few cells in mitosis here.
Yes, sir.
Okay.
And in LSC, we find hypergranulosis.
Yes, sir.
Absolutely. And you don't see this amount of, vertigage hyperplasia, such regular elongation of vertigages to this extent, which are clubbing together. This is too crowded for LSC. Okay. So let's go to the answers here. Case number 5. DLE 15 have called it DLE. I think they've all gone by the clinical. I don't know why. Oh, sorry. So the DLE got no answers. Scalp psoriasis is the only thing that gets any answer actually. Psoriasis from dermatitis, I mean, that's a very non-specific answer, though they have picked up psoriasis. 0.25, sir, what do you think? I mean, specific.
I agree that it's a very non-specific, escapist type of diagnosis. In many of the cases, we will be tempted to sign it off something as psoriasis or dermatitis. I resist that temptation. I either call it as psoriasis or dermatitis. I don't think we should encourage people to use that term.
Okay, fine. We'll leave that off. Then there's no answer to anything else, right, sir?
Yeah.
Only psoriasis, 6 people get the answer. Okay. So now we are left with case number 6 and 7, last 2 cases, which I think are very easy actually. This I didn't even put a clinical because histology is so specific. 30-year-old female with asymptomatic skin-colored papules coalescing into annular plaques over dorsal hands and forearms for 6 months. So that is the clinical history. I think based on the annular plaques, skin-colored papules, I think we've got a clinical differential in our mind. Dr. Vishambu, do you have any clinical differentials in your mind? Without any clinical pictures, it's difficult, but what do you think of?
Granuloma annuli.
Absolutely, that's the first diagnosis, right? Anything else? Asymptomatic. Dr. Priyanka, can you think about any other differentials?
Sir, annular elastolytic giant cell.
Which is in the same spectrum as
Yes,
GA,
sir.
right? Okay.
Yes, sir.
So I think
clinical history wise, I would also consider Hansen's disease among the differential diagnosis.
asymptomatic. Yes, absolutely.
Great.
And histology, Dr. Priyanka, what do you think?
Sir, epidermis is looking flattened, and the upper part of the dermis is unremarkable.
Yes.
Yes, sir. And the pathology I can see mostly in the mid to deep dermis.
Yes.
And yes, sir. And in the mid dermis, I can see some pinkish pathology. Maybe I'm correlating it with the collagen degeneration, and there are many giant cells, sir.
So here is the collagen degeneration right in the middle, right?
Yes.
You see the degenerate collagen bundles here I'm putting right in the middle, thickened degenerate collagen bundle, right?
Yes, sir.
And then you're seeing what are these cells right in the middle? What is the cell that I'm putting right in the middle? What is
they are histiocytes.
Histiocyte. Why is it histiocyte?
So they have a vesicular nucleus.
Yes, and usually slipper shaped or
Yes,
larger, elongated, oblong, slightly more elongated, and slipper shaped is the usual typical feature that we describe. And so yes, degenerate collagen bundles. So this is a is it a granulomatous infiltrate?
Yes, sir. Yes,
and
sir.
This is you're seeing here typical giant cell, right?
Yes, sir.
So you're seeing giant cells, histiocytes with degenerate collagen bundles. I think you're supporting the clinical history, the clinical difference that they've given. I think it's pretty straightforward. Any other features, Dr. Nandakumar, sir, you want to add?
No, this is the interstitial type of granuloma annular. We are not seeing the typical palisading arrangement, isn't it? It's more of interstitial type of granuloma annular. And
so interstitial, do you not expect to be more in between the collagen bundles here?
But
here there is degenerate collagen with, I mean, if you look at low power, here's a degenerate collagen with surrounding granulomatous infiltrate, right? I wasn't particularly, convinced it was interstitial pattern here, but
here I think there is a bit of palisading arrangement is also seen. Yeah, maybe it's a classical granuloma annular event. We can do a special stain for mucin also.
Yes.
Isn't it?
Yes.
Yeah. We can do a Alcyon blue stain
Do
to
you think,
demonstrate.
I mean, would you recommend it before signing out, sir, in all cases, or is it something
No,
that you
no,
ask
I
for?
don't. I don't. In all cases, I don't.
Yes. I mean, in fact, in this case, it looks like more like a red granuloma rather than a blue granuloma that we
Yes,
should
yes,
find.
I agree.
So
But
it's- But all
with the-
granuloma annuli cases don't follow the textbook. So
yeah,
So Dr. Vishwambari and Dr. Priyanka, do you have any doubts before we proceed? I mean, feel free to ask because this is a teaching session. This is not learning session. This is not a quiz per se. We're not questioning you. Quiz you've already done. This is a teaching session. So please
what are the other palisading granulomatous lesions that you would consider?
Sir,
Not,
necrobiology. Yes,
not
sir.
necessarily in this slide, but what are the
Yes,
other
sir.
conditions? Just to
Sarcoidosis.
enumerate.
Sir, nee, sir.
go ahead. You said something.
Sir, NLD, another is a rheumatoid nodule we can consider, or a subcutaneous granuloma annulare, pseudo-rheumatoid nodule.
Excellent. Why is this not necrobiasis lipoidica, ma'am? Or do you think that this should be considered?
Sir, in that we can see some cholesterol cleft, thin slit-like spaces.
Okay. So usually necrobiasis lipoidica is much more deeper. It's not restricted to the papillary dermis. And usually you see tired granulomas. Normally the
Yes,
granulomas.
we see that. I mean, horizontally oriented tiers of granulomas.
And you see some normal collagen, then you see horizontal tiring of normal degenerate collagen. So you usually see horizontally tired granulomas. This is not typically horizontally tired. This is a fairly well circumscribed granuloma. And necrobiasis lipoidica is usually deeper, right? You see tender plaques clinically. So it's much more deeper. The granulomas in necrobiasis lipoidica usually more in the deep dermis, mid to deep dermis rather than superficial to mid dermis. And that is one more clue. Apart from that, deep GA should be deeper and rheumatoid nodule is also deeper. So again, that is against those differentials. Okay, so I think we can quickly move on to the answers. Case number 6, GA is the right diagnosis. This one, all of them got it right. Some people have called it annular elastotic giant cell granuloma. I'm not sure there is enough.
No.
I mean, to say that for so annular elastotic giant cell granuloma, we didn't discuss though. Dr. Priyanka Kove mentioned it. So here we should see some elastin within the granuloma, within the giant cells. And if you see that, then you can make a diagnosis of that. Here, none of the giant cells have got elastin within them, or not visible anywhere. It's all degenerate collagen. So you can't really call this annular elastotic giant cell granuloma. Though the clinical history suggests that it is a photodisplay site, so you may think about it, but histologically it doesn't support it. Annular granuloma, I don't know what that means. I don't know why it's in the thing, but we can't really give any. Actinic granuloma,
No.
that's again elastic variant, no sir. Do you think you can make a diagnosis of that? Should we give some marks to that?
No.
Interstitial GA, somebody is called that. You thought it had interstitial pattern, so maybe
Yeah, maybe we should give 0.75 or 0.5 for this issue.
0.75 I think is okay for that. Yeah, none of them are getting any other marks, unfortunately. Okay. Dr. Priyanka Kove and Dr. Vishwambari, do you have anything to suggest? Any doubts that you have in these differentials that you think need answering? We are happy to answer.
Didn't both of you make the diagnosis?
Yes, both of them have called it actually.
Very good, very good.
They've called it even on the clinical, which is excellent.
Right.
Very keen histology. So this is a interesting case. Again, this is for discussion. I don't think you need to give a specific answer to this. This is a 4-year-old male child with firm to hard painless growth near the lateral end of the right upper eyelid with mild tenderness. Diagnosis cyst or calcinosis cutis. And you can see the the nodule here. So it's firm to hard, painless actually. Mild tenderness present, stays here, not completely painless. And you can see that here as well on the You can see that here as well. And this is the histology. It is a bit difficult, but all we want from you is a descriptive histology to tell us what it is not. So maybe we can discuss what it is not and then take it from there. Dr. Priyanka, maybe you want to do this.
Sir, here the epidermis is thinned. So it is correlating with the site taken from the eyelid.
Absolutely.
And
So don't say thin, just say the epidermis is slightly on the narrow side, but it is normal. So it is normal for that side, right? Not thin.
yes, sir. The basal layer is pigmented, and
Yes.
so I can find the upper dermis is almost normal, and I find it the pathology is in the mid dermis.
Yes.
Yes. And there is some yes, sir. On higher power, I can see the mononuclear infiltrate predominantly.
Is there
What
any?
about these?
So these are histiocytes, sir, again, with a vesicular, yes, sir. Some are slipper shaped and some are round, oval, and with a vesicular cytoplasm.
Absolutely.
And
Some are lymphocytes, some are histiocytes, right?
yes, sir. And sir, I can also make out this foaminess of the cytoplasm.
Absolutely. Yes, that is very important feature in this particular case. And
Yes,
I
sir.
put this up particularly to highlight it. And what are these big structures?
So this is a muscle.
Absolutely, quite
Yes,
right. Excellent. So it's
yes,
that
sir.
is site related muscle. So whenever seeing muscle, think about eyelid, mouth, labia, scrotum. So these are the common areas where you see superficial muscle. So it's very
Yes,
important. And very important, sometimes there may be a specimen mix up. And if you're seeing muscle in suppose a trunk biopsy, which is very superficial, then you know it's something is wrong with that particular biopsy. Maybe it's the site is mixed up. So it helps you sometimes to narrow the site. So
yes.
based on this, Dr. Vishwambari, did you think of any other findings here? Are you there, Dr. Vishwambari?
Yes, yes, sir.
Yeah, don't worry if you have not thought about anything. Feel free. It's okay. This is a very difficult one. I think only people with experience will be able to diagnose it, who have seen number of cases. And I don't think you can give a specific diagnosis. You can only suggest it.
Are we seeing any giant cells? Maybe they are not.
Sir,
some of them do appear like they may be giant cells, but
Yes.
But they are not. Yes.
they can
They are
collagen
not.
with some
Yeah, maybe.
nuclei around it, but they're not definitely giant cells. Okay.
I think the foamy nature of the cytoplasm is a clue along with the site of the lesion, isn't it?
Absolutely, absolutely.
yes, sir.
Anybody, Dr. Priyanka or Dr. Vishwambari, do you have any suggestions? Diagnosis?
Sir, I considered it as a non-Langerhans cell histiocytosis from the juvenile xanthogranuloma based on.
Okay. Okay. Dr. Vishwambari, do you think of anything? Or if you've not thought about anything, don't worry.
No, sir, I didn't thought of anything.
You didn't think of anything. Nandakumar, sir?
There are no eosinophils here. Absolutely no eosinophils. I would, consider possibility of a simple chalazion. That is why I was stressing about that vacuolar nature of the cytoplasm.
Absolutely. That is very typical of this. Unless you've seen a chalazion without a proper chalazion with this is a chalazion. They have biopsied only the superficial aspect of it. If you go a bit deeper, I think you'll see the full aspect of it. But the typical foamy nature of the histiocytes is a clue to chalazion, and that's and the site. This is a case that needs CPC. Without CPC, there's no way you can actually diagnose it. If you don't tell the site, it's not possible. So on histology, it is not, you can have to exclude. That's why I said initially, you should not make a diagnosis of anything else here. The features are not specific of any specific entity at all. It's a lymphohistiocytic infiltrate with the histiocyte showing a foamy cytoplasm. based on the clinical history, this is chalazion unless proven otherwise. I don't know, Dr. Nandakumar, sir, do you think any other DDs can be thought of?
No, I don't think so. I think it's basically an inflammatory lesion likely to be chalazion.
Yes, yes. So it's a very difficult one if you're not seen one before. I don't think you'll make a diagnosis.
And definitely we should do CPC before signing off the report in this case.
Absolutely, absolutely. So let's see what people have called as calcinosis cutis, juvenile xanthogranuloma, as Dr. Priyanka has pointed out. Some people have thought about it because I think they thought some of them are giant cells.
Yeah.
Again, need to do CPC here. So chalazion is the only right answer.
Three people have made a diagnosis of chalazion. That's quite good.
I think there may be general pathologists who may be getting it right.
Correct.
Right? Than dermatologists, because normally dermatologists don't see these cases.
Yes, correct.
So yes, I don't think any marks for anything else. So that's that. Excellent. Dr. Priyanka and Dr. Vishwambari, you've done extremely well coming from a general dermatology background. And do you have any questions or doubts about the cases we've discussed?
No, sir. It was a wonderful learning experience, case-based and one-to-one. Thank you, sir.
Dr. Vishwambari, are you still nervous? Are you okay? I hope you haven't.
I'm pretty much comfortable now, sir.
This is supposed to be a very informal way of discussion. No, we are not trying to assess your knowledge or anything like that. This is just what I said at the beginning, a mutual learning exercise. It has to be very informal. You should be relaxed, very, very relaxed. And we expect to see you in our future sessions also.
Sure.
And that is the whole point of, and any viewers who are sitting at home and watching this, please do, join in these sessions. This is one-to-one. When you're learning one-to-one, I think you tend to commit yourself and then make mistakes, and then that's how you learn. Unless you're making mistake. I had very silly doubts when I was training as in my fellowship. What is this, a lymphocyte? Is it histocyte? Is it plasma cell? Simple doubts, and some artifacts I didn't know what they were. And unless you point them out and ask the teacher, you will never know. And that doubt will remain in your mind. When you see the next case, again, that doubt will remain. And you're like, why didn't I ask about this earlier? And you have to ask about these cases. And that's the reason you have to look at the slides earlier and then make sure that you remember to ask about specific things that you don't know about. And look at the entire slide. Look at areas which we don't know. Some parts you know, some parts you don't know what is going on there. Like that artifact about the pigmented thing that you thought may be a fungal this thing. So look through the entire slide and think about any stupid doubts that you have, please ask. They're not stupid. They're all very intelligent doubts. Unless you clarify them, and everybody goes through that actually. Unless you clarify that, you're not going to proceed as a dermatologist. So excellent, nice discussion. Let's see if the answers are not yet populated by the system. Once they're populated, we'll announce them. Oh, there they are. So Dr. Kalaivani has scored the highest, followed by Dr. Lavanya. Excellent, well done. So we'll be sending out the marks shortly. And everybody has done very well. These are difficult cases. Some of them are not as straightforward. If you're not a reporting dermatopathologist, they are not straightforward cases. So don't shoot yourself if you've not got good marks. It's a learning exercise, and please do keep participating. Dr. Nandakumar, sir, any final words?
Yeah, I'm impressed by the fact that both of you are clinical dermatologists, and your knowledge of dermatopathology is quite remarkable. That speaks about the training that you have had. I'm impressed.
Excellent. So I think we've finished right on time for a change. Thank you, Glodama team, for supporting us, and hope to see you all again. So I'm stopping the sharing now. Okay. Thank you very much.
Thank you. Good night. Bye.
Thank you, sir.